What's going on, everyone? Welcome back to another episode of the Muscle Memoirs Podcast. Today, we have a wonderful episode for you. Joining me is Dr. Emily Dhurandhar. Emily, how are you doing today?
Excellent. Thank you for the invitation.
It's my pleasure. We have a couple of really interesting topics to dive into, but for the listeners who might not already be familiar with you and your work, could you give us a little bit of background about yourself?
Sure, I'd love to do that. So you know where I'm coming from. So I actually received my PhD in human nutrition from Louisiana State University. And I did my postdoctoral or my PhD dissertation work actually at Pennington Biomedical Research Center with Dr. Nikhil Dhurandhar. And he's actually my father-in-law now, but we'll save that story maybe for a different time. But I then went on to do an NIH postdoctoral fellowship with David Allison at their University of Alabama's Nutrition Obesity Research Center. And I then held a faculty position at that same institution for a little while before moving to Texas Tech University in their Department of Kinesiology. And I was there for 4 years. And during my academic career, I have actually published 46 peer-reviewed publications in various areas. It's kind of a smorgasbord of different topics. So those include randomized controlled trials in weight management in adults, the influence of macronutrients and social dynamics on energy balance and eating behavior, the clinical utility of whole genome prediction models for predicting chronic disease, and even viral induced changes in metabolism and obesity and energy balance. And so Richard Atkinson, my academic grandfather, always, said there are two types of researchers. There are dogs who kind of sniff from area to area, and then there are moles who kind of do a deep dive into one specific topic. And I think I consider myself more of a dog, so to speak. And I think I was always kind of searching in my academic career for a research project that would have just simply a big impact on the lives of people with obesity. And to take a step back there is, why is that so important to me? I actually got into this field for somewhat of a personal reason. I grew up really seeing the contrast between actually my mother, who always struggled a lot with her weight, and despite really earnestly trying to control it, and then my father, who was always thin, with really no effort, or without really thinking about it. And I guess it just didn't really make sense to me that that could happen. And I didn't really like the simplistic explanations that society gave me to explain that and to explain the controllability of weight. And so I actually kind of was never satisfied even with the solutions that my mom tried. I saw her trying a lot of things, and some of those things were actually pure quackery, to be honest with you. And I hated that, in the end, she and a lot of the people around her still blamed her for her weight, despite, I saw how hard she was trying to control it. And her story is not unusual. As I kind of explored this more in college, I learned that that's the same story as like millions of people in the world who are trying to control their weight in this environment that we have. And I really wanted to have an impact on the lives of people like my mom and all those others. And so more recently, I realized that I could do this effectively through a position as Chief Scientific Officer of Obthera. And I have actually been in that role for the last year. And we are a company that actually my husband and I built from the ground up. And we create and deploy evidence-based, no-nonsense digital tools for people with obesity and healthcare providers. And so far, it's been really fun and exciting to translate the research directly into products. And it's also kind of a new experience for me, and it's a lot of fun to learn about doing more live experiments. So as we deploy these products, obviously we're evaluating constantly how it's going, and so we can improve them quickly through iterations. And so it's a more fast pace, and I'm really enjoying that a lot. And one of my biggest areas, I guess, of research focus right now in that capacity is just trying to improve the weight loss experience, actually, through both dietary and then communication and education considerations. So that's kind of where I come from and what my background is.
Lovely. Thank you so much for sharing that. I think that gives the listeners a great background of yourself and probably alludes to some of the topics of conversation we'll be getting to today. Whenever I have a guest on, I like to dive into all of their publications, try to connect some dots, formulate some discussion topics. And, based on what I saw from your work, I would definitely describe you as a dog as well. I mean, there's a lot of different angles we can explore within the context of obesity, right? I mean, sure, you could just take one specific aspect of obesity and dive into that rabbit hole, but there's just so many different avenues that you can go down. And I think, that's ultimately why we're dealing with the current problem we are in this country and around the world as it is, right? Because it is so complicated, and that we can't really just attribute it to one thing. There's so many factors that we need to control in this equation, right?
I agree with you. You're absolutely right.
So I want to come back to obesity, in particular, your app. I think that's fascinating. I love it. Technology is the future, right? And if we can make evidence-based dietary interventions more easily accessible and widespread to the public, I think that's phenomenal. So I'm excited to get back to that. But before we do so, for the first half of this podcast, we're going to be talking about a recent publication of yours titled Normal Weight Obesity and Unaddressed Cardiometabolic Health Risk, a narrative review. Now, before we get into the details of this paper, I am curious about the origin story, so to speak, of it. So this is obviously a very novel concept, right? Like we don't have much direct evidence on it. There's a lot of really interesting points within this paper. So how did this idea come to be?
Yeah, so actually this was through a collaboration with my postdoctoral fellow, Dr. Nadija Wijayatunga. So she is from Sri Lanka, and she, was a physician there, and noticed that, her patients were experiencing cardiometabolic complications at much lower weights than the patients that she reads about here in our research. And so I actually have experienced that as well in practicing nutrition counseling in India, through part of my role in our company. And same thing, we see that if you see a lot of people that we work with in India have a normal BMI, but they have an elevated body fat percent, and the things that come with that. And so she and I recognized how important this was, and there was quite a bit of literature on it when we decided to do this review. But you're right that it's a very nascent kind of new thing that people are looking at, and so we just wanted to kind of wrap our brains around it, and that was the evolution of this review paper.
Fantastic. So, start us off here, set the stage. When it comes to normal weight obesity, what exactly are we referring to here? What's the criteria for it?
Yeah, so I guess technically it's anyone with a BMI between 18 and 25, but with an elevated body fat percent. And the exact cutoff for what elevated is actually not widely agreed upon, but I think it's safe to say that, as even within this normal BMI range, as the percent of the body made of body fat increases, the health risk also increases. And I think a widely used cutoff that, was more common in the literature, but again, not universal, is above 25% for men and above 35% with women. If you had to, make a cutoff, that one was pretty consistently associated with an increased health risk.
And on the topic of that increased health risk, I think for those who really aren't into the nuances of the research, they might be surprised to hear this finding, right? We have someone with a normal weight BMI and they have an increased health risk. I mean, you hear all the time, right, that just maintaining a normal, healthy body weight and the rest kind of takes care of itself, right? Outside of a couple of outlier scenarios, right? When BMI increases, we're typically going to see a relative increase in cardiometabolic, the risk of cardiometabolic disease. So, what's going on with normal weight obesity that results in this elevation of risk?
As far as the underlying etiology, that's something that the research is just starting to emerge about that. And I would say that there are a couple of factors that we definitely see are consistently associated with normal weight obesity, and one is age. So that's one of the really strongly associated factors. As people get older, if they're of a normal BMI, they're more and more likely to have this normal weight obesity phenotype. And that could be related to just muscle loss, as we age. That's a pretty normal, well documented phenomenon. The other thing that is associated with it is race. And so we do see that the body fat amount per unit BMI is higher for Chinese, Hispanic, South Asians, all compared to white and Caucasian individuals. And so, in fact, actually, South Asians in particular have the highest visceral fat for a given BMI compared to all of the other races. So that could be playing a role as well. Sex is another factor. So females are at higher risk than males, and the prevalence of normal weight obesity is also higher in Chinese and Caribbean males than females. So it's the opposite. And just Chinese and Caribbean males have more risk than females for some reason. So that's, pretty consistently females, except those two particular races. As far as lifestyle is concerned, interestingly, the results on diet quality and normal weight obesity are very, very mixed. You see some studies that show that there is an association, as you would expect, with poor diet quality and normal weight obesity, but other studies show the opposite, that people with normal weight obesity, have some healthier traits than normal weight lean. And so I feel like right now the research on that area is very unclear, and it could even be that any associations we're seeing are just spurious. So that's kind of interesting. But when it comes to exercise, we do see pretty consistently that cardiovascular fitness is associated with normal weight obesity, so lower cardiovascular fitness for those with normal weight obesity. And again, there's some challenges, I think, with the methodology of measuring exercise, but most studies are also showing that people with normal weight obesity exercise less than those who are normal weight lean. And so I do think there could be a role there, lifestyle-wise, for exercise. And then with genetics, most of the work in genetics in this area has been done in Caucasian females. So definitely take this with a grain of salt. I think we need a much more comprehensive look at this. But at the moment, it looks like there's some evidence of normal weight obesity being associated with some polymorphisms and obesity-related inflammatory markers. For example, there's a polymorphism in the IL-1 receptor antagonist that is associated with normal weight obesity. There's also an association of normal weight obesity with a polymorphism in the MTHFR gene. And actually, that might explain why people with normal weight obesity have elevated homocysteine levels, which is known to be a cardiovascular disease risk factor as well. And so that's very preliminary, but interesting, I think, work in the area of genetics as well.
That note on cardiovascular fitness is pretty interesting because, correct me if I'm wrong here, but I believe when it comes to metabolically healthy obesity, there's that correlation there too, right? So people who are with metabolically healthy obesity, they tend to have higher cardiovascular fitness levels. Is that correct?
Yeah, that is true. You're right. And that may protect them.
Do you have, I don't believe we touched on this yet, some insights on the current prevalence of normal weight obesity, at least in the United States? I believe most of the listeners are from the United States, so it would be interesting to know those stats if you have them.
Yeah, so I think one of the better studies on that looked at HAES data, where, on people who had both body fat percent and BMI available. And that paper was published in 2010, estimated 30 million Americans may have normal weight obesity. It's a lot.
That is a lot. I mean, it just makes you think, right? Like, how many people every year at their physical exam are going into the doctor's office, just getting, the basics done, and they're just being completely bypassed more or less by their healthcare professional because, maybe body weight hasn't even changed in like 5-10 years. But and it's just like, oh, normal BMI, you're a normal BMI every year. But in reality, there's some metabolic abnormalities going on there that are a concern.
Absolutely. Yeah, I think so we actually looked at that, at how, often that might be missed, and we were unable to find any literature on that. But I do know that, the standard process in a physician's office or, nurse practitioner, any healthcare practitioner's office, is to measure weight and height and calculate BMI. And if the BMI is normal, to kind of just move on. You're right. And I don't believe that I'm not aware of any clinic that uses body fat percent or waist circumference as kind of a standard anthropometric that they take in all of their patients. And so I think it's very likely that, especially when it comes to, prevention of future cardiometabolic disease, I think it's missed probably the majority of the time. And I think that it's unfortunate, but it's probably only caught at the point where someone has a risk factor that shows up, like high blood pressure. And even then, I think the route is more typically to treat the blood pressure, for example, and not necessarily bring up the fact that potentially a reduction in body fat could help. So that's really not well understood, as far as we're just kind of making assumptions at this point about what's going on. But I think it's safe to assume that it may be missed quite often.
Definitely. I mean, we have studies showcasing insulin resistance in like college age participants, right? And I mean, I run into it all the time in practice, people who aren't really concerned about their health, that they have a normal weight, and corresponding with that, they might have they don't care too much about their diet. Physical activity is low. They might have a desk job, but they'll hear from people around them or whatever, like, oh, look at you, you're skinny, you're completely fine, like you don't need to change the way you eat. Physical activity, if you don't really feel like it, like, there's no need for an intervention. You're young, and you're healthy just because you have a normal BMI, so we don't need to look into this any further.
Absolutely. And actually, my postdoctoral fellow, Dr. Nadija Wijayatunga, she got a grant from the American Heart Association called the Adiposity Awareness Study to look at exactly that, as how aware of health risk are people with normal weight obesity. Because I think you're absolutely right that, especially with the absent, more common social pressures to lose weight, or because it's a very visible thing, right? If you have typical obesity, it's something that most people can see, but with normal weight obesity, it's just not so obvious. So that social pressure is missing, that's there. And so I think there's a lot to look at there as well. You're right.
The differences between races and ethnicities is so interesting. It brings me back to a podcast episode I did with Dr. Roy Taylor, right? So he more or less pioneered this whole concept of the personal fat threshold, and how it can be so confusing to so many patients that their BMI is normal, yet they're either pre-diabetic or they have full-blown type 2 diabetes. And there is all of this research demonstrating these significant differences between populations. I mean, literally, someone sent me this recently published prospective cohort study last night, and within this paper, they basically put forth that in South Asians, a BMI of 24 is more or less equivalent to 30 in Caucasians.
Yeah, with our treatment in India, we consider a BMI 23 or less is what we're trying to get for health. 23 and above is associated with increased risk. That's right. It's very different. And you're right. It seems that with South Asians, they may have a different threshold for fatness, and the actual amount of body fat that results in adipose tissue dysfunction and inflammation and insulin resistance and all the things that result from that.
Before we leave this topic, obviously there's so much work to do in this field, but for you, when you consider the research that needs to be done to get more answers, what are you primarily interested in? What would you like to see first?
I think, in digging into this a little bit for this review paper, what struck me is how little we have even characterized this specific condition, and how much groundwork actually there still is. I think it would really help if people in this area could maybe come together. I think actually it could be something that is the topic of, like one of those bigger conferences, where everyone studying this gets together and kind of tries to come to some conclusion about, definitions. And then I think to draw attention and maybe funding to the area, I think it would be an important starting point as well to understand that public health burden of this. Like, how often is it being missed in the examination room? I think that would draw attention to this, and from there, then we can get better funding and more interest, I guess, from talented researchers to understand better the etiology for maybe pharmacotherapy targets or interventions that from the literature so far, it seems like focusing on exercise interventions might make sense. But again, it just seems like there's a lot of basic groundwork to be done at this stage, and it's an exciting new field, actually.
What do you think would be the most feasible approach to get into your common general practitioner's office in order to identify these people with normal weight obesity? So, obviously, as we touched on here, the scale is probably not enough to get the job done. Can we just throw in a waist circumference measurement, or should we expand further to really get some more insight into what might be going on?
Yeah, I think that is a little bit challenging because, your more common office and clinical settings, you could probably use like a BIA machine. But I think the struggle there is, the standard of error is like 3 to 4%. And so it's not, the most accurate measure to kind of get that cutoff. I think as far as reliability in a clinical setting, I think you're probably going to maybe get some more consistent results with waist circumference and maybe waist to hip ratio. And so I think that, studies that, and that's also very simple, very inexpensive to do. So I think that would probably be a good starting point to make progress and understanding the prevalence of this and how often it's addressed and all that sort of area.
Fantastic. Just to mention again, I really do enjoy this paper and I appreciate your contribution. It's much needed as someone whose roots are in the fitness industry. We hear about a similar topic all the time, right? The client presents their case to you and it's, I'm skinny fat. Do I need to lose weight? Should I just focus on building some muscle? Like, what do I do? And it's like, I'm all for aesthetic goals. I encourage everyone to do what makes them happy, but we need to consider what's going on underneath the hood too. And this paper highlights that. So wonderful stuff. And thanks again.
Yeah, I'm glad you found it interesting. And I really have to thank Nadija on this one. She's kind of carrying the torch on this area and she's really excited and passionate about it too. So definitely want to acknowledge her too.
Absolutely. Now let's transition to a more controversial topic. Let's get into weight loss culture. As an obesity researcher, I follow you on Twitter. You're always making very great points about the nuances within this topic, right? People like to settle into their diet tribes, say it's this thing or it's that thing, and we miss a whole lot of nuance. And you're doing so much great work in terms of your research, what you're doing on social media with your app. Obesity is a complex issue. It's something we talk about on the podcast all the time. So I love to hear some thoughts from experts in the field. To start out with a pretty general question for you, when we look at what's going on in the current nutrition space, there's sort of a revolt against weight loss, right? There is the emerging side of intuitive eating, health at every size, and they make a lot of excellent points. I think it's wonderful that we have camps that are putting out an alternative perspective to the mainstream notions within this field. But when we have these very strong opponents to mainstream ideas, sometimes again nuance can get lost, and we become attached to putting forth a very specific point that might be lacking the details necessary for a listener or a reader to fully understand the entire picture. So I want to ask you, when you see everything that's going on within weight loss culture, and in particular, those who are kind of against active restriction or pursuing weight loss intentionally, what do you think this side of the debate is getting right? And where do you think some of the message is getting lost?
Yeah, I appreciate your appreciation for nuance and I appreciate your compliments. I think, it's not sexy to talk about nuance necessarily. It's much easier to just digest a simple truth.
We'd have more listeners if people like nuance.
Yeah, that's right. I think so. But the truth is always in the nuance, right? So I appreciate you bringing this up. I think I just want to start by saying that the revolt against weight loss, this is my opinion after engaging quite a bit with HAES advocates and fat acceptance groups. My impression is that it's coming from a very heartfelt place, and it is absolutely in the defense of the well-being of people with obesity. And so I think those who are against weight loss or revolting against weight loss, I think that, in my discussions with them, they often say weight loss doesn't work, or it does harm, or the weight is just regained anyway. And so they say it's a pointless treatment, and it puts people through undue stress, and it puts them through harm. And I think there are some truths to that, unfortunately, with the current state of affairs. But I do think that there might be a better version of the future that, doesn't involve harm to people with obesity and still involves weight loss. And so the way I think about it is this. So the success rate of CPR, for example, is 12% outside of a hospital setting. Yet we teach it to everybody, right? Even, somebody just who is standing next to the pool at a fitness center or standing by someone's workout, they know it, right? We teach it to everybody, but it only has a 12% success rate. And so we don't dismiss that, right? Because it does in the end save someone's life. And so I think of weight loss therapies in kind of a similar light that, even if it can't help everybody, it might be able to help some people. I think that the trick is making sure that people who are engaging it actually understand that. And just FYI, actually, it's true that 20% of people who try to lose weight through diet and lifestyle actually do lose 10% and keep it off. So it's actually got a better success rate than CPR, to just kind of put it in perspective. That being said, I do think that a big part of this revolt against weight loss is well-founded, and it lies in the fact that most people, including healthcare providers, are not taught a really good and evidence-based framework for offering obesity treatment. And so this can result in kind of an oversimplified approach that can alienate people. Would it help if I give some examples of that, maybe?
Absolutely. Yeah.
Okay. So, and again, this is from, my discussions with HAES advocates, with our own clients, with my own experience in working with people. They've told me about, what they've experienced. This is from my work with the advocacy committee of the Obesity Society, the advocacy work I've done with the Obesity Action Coalition. So this, again, is just my aggregate from my discussions and my experience. But a lot of people will cite an issue of sometimes in the physician's room, or even with just family and friends, they feel kind of guilted or shamed into losing weight through diet, like it's a moral imperative. But in reality, it's just one of many treatment options. It's not something that should have any moral undertone to it. It's just one thing that could help and manage, health with obesity. And another thing that's often said is that it's done in a way that makes people kind of feel like their old way of eating was bad and the source of the problem. Like they need an overhaul, right, of their whole lifestyle and their whole diet. They've just been doing it all wrong. But I think really we need to recognize that overeating is a symptom of a disease that they have. Again, removing that moral undertone to it. It's not good. It wasn't bad. It's just a symptom that was present. Just like I had a cough because I had a cold. That's how we need to look at that. And then often people will say that it's done in a way that makes it feel like the patient's individual success or failure, and not the success or failure of a treatment. Like if you take an antibiotic and it doesn't work and doesn't, kill your infection, you don't sit there and think that your character is somehow flawed. Why is it any different, right, with a dietary treatment for obesity? That doesn't really make sense to me. And then I think also sometimes it's done with like the promise of a specific amount of weight can be lost. Scientifically, we still do not have a good model for predicting how much weight someone's going to lose in response to a treatment, even with 100% treatment fidelity. And so I don't know why we're allowed to make promises about how much weight someone can lose. I can understand that you might want to give some statistics about typical responses and average response and maybe, the range of possible responses. I can understand that, but don't make a promise because then someone, again, because of the narrative around obesity in society, they'll feel like it's their fault if they don't achieve that. And that's not fair to the patient. I think also a lot of times it's done without any sympathy of the side effects that come with weight loss. I think we need to respect the fact that we're asking someone to starve their body essentially in a way that's safe and ideally in a way that's comfortable. But if it's not comfortable, I think it's important to listen about the discomfort and help the patient weigh kind of the side effects and the benefits that they may be achieving with the treatment, and maybe troubleshoot that. Like if something's not working, if something's not bearable about a specific lifestyle change, if they're uncomfortable, then we should hear that and respond to it, like we would with any other, treatment modality. I also think, unfortunately, it's often done to the exclusion of other perfectly valid and medically viable treatment options that also should be discussed. So we should never do dietary therapy in lieu of pharmacotherapy or bariatric surgery if those are also indicated. And I think that's happening a lot with healthcare providers that might not be comfortable discussing pharmacotherapy, or they're not comfortable with bariatric surgery for whatever reason. And so that's a problem too, because then you're only offering, one arm of, 3 potential arms of treatment. I also think a lot of times it's done in a way that's kind of a one-shot deal. But again, like anything that is physiologically regulated, like body weight, the approach and the treatment needs continuous monitoring, and there might be calibration to the approach. There might be, addition of another therapy on top of the one that's already happening, depending on the response. And so I think a lot of times we don't have a good system built in for that kind of continuous monitoring that's really needed for someone to lose a meaningful and clinically meaningful amount of body weight. I think it also is sometimes done for a surrogate, for a rigorous assessment of symptoms that are being presented, and that can be really discouraging for some patients. So, for example, if someone comes in with severe knee pain, instead of doing a thorough investigation of the knee and treating the pain of the knee, it's recommended that the patient just lose weight. And then support for that weight loss is not even offered. And so that feels, I think, like a little bit like abandonment, for the patient. Like, because of my weight, I'm not able to get treatment for my knee, just as, one example. And then 2 more that I've noticed. One is that sometimes it's done in a way where there's not a lot of rapport between the patient and the provider, such that the patient trusts that if something's not working about what the provider suggested, they can actually tell the provider that without the provider not taking their words seriously or not trusting that they actually tried. Because that's, again, a common thing that I think a lot of providers feel like patients with obesity are not motivated, but in reality, they are often very motivated, but the particular approach just isn't intensive enough, or wasn't sufficient given their particular, etiology of obesity and the pathophysiology that's going on with them. And then finally, sometimes I think it's administered by someone who presents only one way of losing weight, dietary therapy wise. And it's like my way or the highway. But I think we need to recognize that eating is so personal to people. And it's hard to have a one size fits all approach that, is actually going to work for a lot of people. So I think that ideally, the healthcare provider working with a patient understands that the dietary parameters that actually matter for weight loss, so that they can offer maximum flexibility to the patient, so they can find a way that they can succeed. And so that was a lot, but that's just kind of, again, a summation of what I've learned talking with patients.
And it was absolutely phenomenal. So many excellent points I'd like to sort through there. The first thing that comes to mind is, of course, in reference to the last thing you said, and it also relates to some of the other things as well. But basically, the fact that when a diet doesn't work for you, it's not a moral failing of the individual, right? Like it's not their fault the diet doesn't work. And we're both involved in nutrition Twitter, and it's just like, how many times I've seen in a comment section of someone who like gained weight on a ketogenic diet, and there's like at least one person who's like, you just didn't do it right, that's why I didn't lose weight. Like it's so ridiculous. It is just absolutely ridiculous.
Yeah. I think there's a lot of experiential bias, where because I did it, I'm an expert. I think, again, in a field where there's quite a bit of uncertainty, it's so much to sift through that I think experience just holds a lot of weight in these conversations. And that's unfortunate.
And on the topic of, obesity being some sort of moral failing, perhaps I don't know what it's going to take in order to kind of transition what seems to be a mainstream thought, at least in some populations, like the fitness industry, for example, that tends to be, most practitioners see that's something that they put forth. There's I think people are doing a much better job of educating the public on why it's most certainly not, with all of this research from the likes of Dr. Stephen O'Rahilly, right? Putting forth that this is an issue of genetics. Like, the root of this disease is ultimately driven by something that's more or less completely out of your control, right? We know that there are these differences in what's going on in the brain, and these sensations for just your appetite throughout the day, how much a meal drives a satiating effect. It can be the same meal can have a completely different effect between two people. One is stuffed, the other is like, am I going to get another one? Like that, I didn't register any satiety from that. And these are things that are completely out of someone's control, which I think is just, it's so important to highlight. And this, the contribution of genetics, it needs to be reinforced. People need to have a better handling on the science before they put across these fallacious claims that, anyone can lose a significant amount of weight. It's easy, calories in, calories out. That's all there is to it.
Yeah, I agree. I think, it's easy for someone, an example I often use for that is that it's easy for someone to see someone with anorexia and see that, they're just maybe disgusted by food. They never want to eat. They're very, very thin. It's easy for someone to look at someone with anorexia and say, oh, that must be a condition, that's something in their body that's happening. If that's the case, if we're able to see it that way, I think, and thinking about from that framework, why is it that we can't understand someone with very, very high weight has something similar, but the opposite going on? It's as a dysfunctional state as anorexia is. So sometimes helping them look at the norm that's unfortunately, the condition and the extreme that's unfortunately idolized a little bit still in our society, having them think about, the opposite can sometimes be helpful.
Yeah, I think that's a fantastic way to put it. Another thing, I think you started off here, but when we look at the HAES community, I couldn't agree more. I think it all comes from, a really good place, and why movements like this are needed is because, frankly, as you mentioned, my experiences align with this as well. There are just so many people who have been chewed up and spit out by the diet industry, where they are completely exhausted, both physically and mentally, from just consistent attempts at weight loss, just diet through diet, without having someone in their corner to really systematically drive an evidence-based process that could work better in their favor. But something I see from this community that's a little outlandish, that probably needs to be corrected, and something you touched on, is that I always see this statistic of, like, only 5% of people can lose a significant amount of weight and keep it off. And I believe, last time I looked into a reference here, it might have been from the 50s. It was a review. I forget who the lead author was, but you mentioned there that based on the latest evidence that this is 20%, and that is, that's a significant figure. That's not something that's negligible.
Mm-hmm. That's certainly better than nothing. And I acknowledge that the evidence-based, what should be the standard of care is currently not the standard of care. So I acknowledge that, it's not that accessible, but when people do access it, I think it's important to recognize that it's, about 20% of people that can lose weight and keep it off. And honestly, for those who don't lose weight and keep it off, I don't understand why. I mean, I get it, why we're obsessed with the idea of weight maintenance. That's what we all want. But obesity is a chronic disease. And so if we stop administering the treatment for diabetes, what's going to happen to someone's blood sugar? It's going to start going out of control again, right? And so if we think that weight loss is some temporary thing that's just one and done, if that's how we think of it, it's the people who get the support that they need to continue that can maintain that weight loss. And, there are some people that may choose to not engage with that support, and that's their choice, and they have every right to choose that. And why would the weight not come back? Right. I I just think that it's not surprising that weight maintenance is a challenge. And that I think that, for me, with my clients, I try to normalize the idea that the weight might come back if you don't, continue the behaviors that you've learned while we're working together. And that's okay. Just come right back and see me. You know what to do. Again, just remove the moral undertones from that. And just respect that maybe someone isn't happy doing what's required to maintain their weight loss. And that's okay. They can come back and do it again if they get to the point where their quality of life suffers so much that they want to re-engage with treatment. What's wrong with that? That's my feeling on it, at least, is that I think our obsession with weight loss maintenance is also misplaced. We need to recognize this is a chronic condition that's going to come back if people don't continuously treat it.
Yeah, very well said there. When Alan Flanagan was on the podcast and we talked about long-term weight loss maintenance and kind of the nuances of this, we ran through, the variables of weight loss maintenance and what behaviors and factors tend to result in success. And, we ran through diet, and there's some good stuff on physical activity. But ultimately, the number one thing that seems to be consistent across studies on this topic is that just continued support throughout this process is the number one thing that, as far as predicting success, this appears to be the most valuable player in the equation.
Mm-hmm. Yeah, it's just kind of a continued support system to, help you stay accountable and focused, because that's what it requires: accountability and focus. Makes sense.
On that point, I want you to tell us a little about your app and kind of correspond this with another discussion topic I have for you. It's something you said that I think was really interesting, and it's going to open up a fruitful conversation, and that is people with obesity, they need innovation. They don't need one more person just telling them how to eat. Just eat these foods and that's the recipe for success. So tell us about your app and tell us about just the power of innovation and how we can potentially evolve this field to develop some more successful strategies.
Sure. Yeah, I'd love to chat about that. So I think to get into that topic, I think to clarify upfront, it's my view that, telling, as far as what is the traditional most common thing that happens now, usually it's, some general pointers, probably very well founded in how to eat better or change your nutrition. And it essentially kind of boils down to, telling someone to eat less and move more, right? And so maybe some strategies to do that. And I think, or maybe just eat less fast food and eat less junk food. So I think that's kind of the traditional status quo that still happens most of the time. But I want to really distinguish that from what I believe is actual evidence-based treatment. And here's, in my mind, what is evidence-based treatment for weight loss. It's intensive behavioral therapy that, focuses on eating behaviors and exercise behaviors mostly. Sometimes it's sleep, stress management. And there's also pharmacotherapy to support lifestyle interventions. And then there's also bariatric surgery. So if you're not actually doing one of those three things, then if you're doing anything other than that, in my mind, it's not really evidence-based treatment. That's not to say that people can't find their way through, the trial and error of different commercial programs, or maybe a diet book after diet book, and maybe find a decent one that kind of works for them. It's not to say that that's not possible, but that's the exception to the rule. And I think we definitely see that, given that obesity rates are still as high as they are, and that's what most people have access to. But I think access to evidence-based treatments actually needs to be more standard than it is, and it needs to be more streamlined and simplified than it is. So the number of healthcare practitioners, for example, who actually have the capacity to offer these three evidence-based treatments that I mentioned is very small. So practitioners certified by the American Board of Obesity Medicine are actually trained to offer these treatments. But there are only 5,200 of them right as of right now in all of America and Canada. So finding one is like finding a needle in the haystack, and you may have to travel very far to get to one, and then insurance coverage may be an issue. And actually, even if you're nearby to one, insurance coverage is often an issue. So many states still don't cover bariatric surgery and hardly anyone covers pharmacotherapy for weight loss. And so you're paying out of pocket for those things. Intensive behavioral therapy is technically reimbursed by Medicare, but most physicians don't know that and don't know how to offer it. That's not something they've been trained necessarily to even offer. And so healthcare practitioners in general who are not ABOM certified are really underprepared, I think, for offering these treatments. And they also have very little incentive because their reimbursement structure is oriented towards treating the comorbidities associated with obesity, but not obesity itself. And so I think what we have here is an opportunity. There's actually some really low hanging fruit here, in my opinion, for innovation that just simply starts by making these, known and safe treatments more accessible. So there are healthcare systems that, may need to be restructured to recognize obesity as a chronic disease and treat it as such. And tools to, support healthcare practitioners and patients are desperately needed. And obesity is a complex condition that's going to require, modification of both environmental and physiological factors. And that requires frequent communication between providers and patients. And it also requires that providers are comfortable with those discussions. And so I think that there's a huge opportunity here for people who, understand and study obesity to kind of bridge that gap and with CME courses and by making sure that medical schools are incorporating more of this stuff into their curriculum. And I think also we need to recognize that this is a chronic condition. And so it has no cure, right? And so that's going to require lifelong support. And so just as there's regular follow-up, like even when cancer or your diabetes is in remission, you still have regular follow-ups to make sure it stays in remission. And so similarly, we need a system to support that kind of long-term follow-up and care for people with obesity. And so I feel like there's a lot we can do with what we already have. But a lot of that innovation, I think, just needs to streamline and just make these access to these treatments a reality.
Yeah, absolutely. Now tell us a little about your app.
Sure. Yeah, I'd love to. So right now, what we have is, I think we recognize again that those general pointers for weight loss are kind of, I think over, 6 months, maybe a year, they can produce some significant weight loss and probably, a healthier overall quality diet. And so there are lots of pros to that. I'm not saying that that's not helpful. I think it is. But I think what we said is that, so this actually stemmed from my grandfather-in-law who started an obesity medicine clinic back in 1962 in India before it was even a thing. Like dietetics wasn't even a thing in India at the time. And most people were focusing on malnutrition. But he decided to focus on obesity. And he honestly just kind of listened, without much judgment to what did people need to lose weight. So he understood, the first law of thermodynamics, that they needed to eat less, but recognized that they needed help to eat less, right? They're not nutrition experts. And so what he did is he wrote prescriptive diets for people that were prescriptive, but also very flexible and left a lot of autonomy to the patient in the way it was written. So they could learn like, okay, with my rice or with my curry, I can have this much and make it in this way. And then I can lose weight. And so then my father-in-law, Nikhil, came here to do research and, learned, and he and I both learned a lot more about, macronutrient distribution, psychological things that improve adherence. And so we decided to kind of take that approach that they used in India for so long, it actually in over 200,000 patients that they treated, and we decided to digitize that. And so the idea is it's kind of like a dietitian in someone's pocket. People can build their own meal plans. It offers the kind of support with the kind of insight that I hope I provided to you today, as far as like helping people understand their condition so that they can actually make progress from a place of understanding, not a place of misunderstanding. And so there's a big education component to the information that's in there that I think is kind of unique. And then that very, very intensive dietary support. I would say we've managed to achieve clinical grade dietary therapy for weight loss in an app. And so we're just very excited about the potential of it. Even like, dietitians, for example, could probably use this to, to save time. A lot of times they spend so much time meal planning, but instead this app could do that, and they can actually focus on maybe the troubleshooting and the behavioral and the understanding part, the education part. So we're just very hopeful about how it might be able to streamline dietary therapy for obesity. It's very exciting.
That is very exciting. I think it's much needed. I'm not too up to date on the latest that's going on in terms of different softwares that people can use to help expedite their weight loss. But of course, there are a number of applications which are more or less just nutrition trackers, right? Which can be super helpful for people to gain a better understanding of, how much they're exactly eating and the nutrient content of the foods that they regularly consume. But without that support to really cement the process and ensure that we're developing positive behaviors and ones that can last potentially a lifetime, I think we're kind of missing the forest for the trees. So the fact that you're kind of combining all of these factors and like you said, having more or less, a dietitian in your pocket, I think that's super cool and it's really exciting for the future.
Yeah, thank you. And I think, the burden being on people to track everything and being a nutrition expert, we just take that out of the equation. The foods that what they get is individualized for them, and there's zero guesswork. They learn by doing. They see, okay, when I eat my favorite foods like this, I can lose weight. And so they don't have to be nutrition experts. They just do it and see it. So the learning is also, I think, very simplified. They learn by doing.
Great. Emily, that is all I have for you today. Thank you so much for this time. This has been a wonderful discussion. I really enjoyed it. I know the listeners are going to get a ton out of it. For those who want to go and learn more about you and support what you're doing, where can we point them towards?
Oh, that would be great. So my Twitter handle is at Emily Dhurandhar, so you can follow me there. And we also have our site, Obthera.com, Obthera.com. Thank you, Mike. I appreciate this, and it was a lot of fun.